Thank you. Okay, so thank you for inviting me to kind of talk a little bit about the Jada vacuum system for use for abnormal postpartum bleeding and postpartum hemorrhage. This talk, as well as these slides, are part of the company. And this program is not an accredited CME for this one here. And I do work and consult for the company Oregon, just a disclosure to start off with. So some of the things that we'd like to review today in the presentation is to kind of outline some of the instructions for use and the procedural steps associated with use of the Jada system, to understand the clinical evidence from the pivotal study, the Pearl study, on its use, and discuss some real-world use of Jada in different clinical scenarios since its approval and adoption into a lot of the different algorithms to treat in different hospital systems throughout the US. So we wanted to start off to kind of make this a little bit more interactive with some polls. And the first one is, what is the most common cause of postpartum hemorrhage? And the options are tone, which is your abnormal uterine contraction, also known as uterine atony, trauma of the area, tissue with retained products, or thrombin, an abnormality in the coagulation. I think there was going to be the option to share for the poll, but we can give a second to think about it, and then we can kind of move on from there. Oh, there it is. Okay, so overwhelmingly, about 85% of you answered that tone is the #1 cause of postpartum hemorrhage or abnormal uterine bleeding, which is indeed correct. When we talk about postpartum hemorrhage, abnormal postpartum bleeding, essentially it's excessive blood loss after childbirth. The most common cause, accounting for about 80%, is indeed uterine atony. And this is due to a tired, fatigued uterus that's unable to contract and stop the bleeding. So when we talk about ways to kind of help with this abnormal postpartum bleeding or postpartum hemorrhage, we'd like to think of it in several different ways. So interventions to help that uterus contract in that setting of atony. So the bimanual massage, as well as your prophylactic Pitocin or oxytocin. And then kind of as we spoke about in the first lecture, some of the uterotonics or drugs to kind of help with that uterine contraction in addition to more uterine massage. Another method to control the bleeding is a little bit more along the lines of application of pressure. So your uterine balloon tamponade, uterine packing kind of fall within that category. And then the more later in the algorithm to kind of remove the source of the bleeding or to really shut down that bleeding is more like your uterine artery embolization, ligation, as well as your compression sutures and more definitive treatment with a hysterectomy. So when we think of this Jada system, it's intended to provide control and treatment of that abnormal postpartum bleeding. And it really is to work more on using that muscle to kind of contract with that low wall suction vacuum, kind of stimulates that physiological contraction of that myometrium that we're trying to improve. And this is really a system that's used more when conservative management is warranted. So it's not necessarily indicated for those individuals that have already lost significant blood, that are clinically unstable, requiring, more surgical interventions and more aggressive surgical management. So for introducing this system here, you kind of see a depiction of it here on the screen, and we can kind of go over the different parts of it. So up at the top, you'll see kind of to the left of the screen, the intrauterine loop. So it is covered with green silicone plastic, which is very soft and kind of malleable to the space. And there are multiple pores kind of on the inside there that allow to evacuate the blood in the uterine cavity. And as we come down, you see the expandable cervical seal. So kind of that green area here that's kind of inflated. So this here is what we fill saline in through the seal valve at the bottom to kind of occlude that opening to create the vacuum inside the uterine cavity. So when we place it, that's deflated, and then after placement, it's inflated. Then you see the transparent tubing. This clear transparent tubing kind of comes out through the vagina, and it allows the providers to really see the blood kind of flowing in there. And I think that's a very reassuring sign that it is in the right position and working correctly. And as we go down more to the lower right part of the screen, you can see the seal valve. And there's where we attach the syringe to inflate that expandable cervical seal or deflate it. And then you see your vacuum connector, and that is where the tubing attaches and then goes to your regulated vacuum source for suction. And that varies with different hospitals and different hospital settings. They can be wall suction, portable suction. It varies there. So this device can be used following a C-section or a vaginal delivery, and it's intended for use by any of the healthcare providers that are really trained or experienced in obstetrics. So we're just going to do another poll. If any of you have ever used a cervical ripening balloon or even a uterine tamponade balloon for either induction of labor or treatment for postpartum hemorrhage or abnormal uterine bleeding. Okay, so it's about a 50-50 split with just a few more not using this. And the reason we kind of asked this question here is I think that when we talk about putting this device in, if people are familiar with putting anything in through the vagina, into the cervix, or into the uterine cavity, the Jada device kind of follows a similar mechanism of when you place it. For most of the time, people just use their fingers and kind of guide the loop into the intrauterine cavity. However, if you do have a longer, really not effaced as much cervix, the utilization of like a ring forceps on the anterior lip of the cervix also helps to kind of facilitate passing of that intrauterine loop into the uterus. So here is kind of a depiction of how you place it. It's easy to use, soft device. So that silicone loop kind of goes inside the uterus, as you see here in the first image, all the way over to the left. And you can see there that that expandable cervical seal is deflated when it's placed. When you open it in the package, it is insufflated with air, and usually we will deflate it, kind of that swooshed up green area there. That is usually placed right around the outside of the cervix, so the external os of the cervix. Once it's in place, then you'll see in the second picture there that we have expanded that cervical seal. So you'll see that insufflated there. And you start to see some of those little white arrows inside the uterus. And that is to kind of mimic that we have turned on that low level vacuum of about 80 milligrams of mercury, give or take 10 on either side. And then as that vacuum starts to work with that continuous suction, then you see in the last picture all the way to the right that there is indeed a uterine contraction, and that is when your bleeding starts to subside and improve. And you would see blood in that white clear tubing in a more accurate depiction of this. So regarding some of the different mechanisms here, the vacuum setting is usually on a regulated vacuum around 80 milligrams of mercury. This is very, very low. This is a very similar setting to what we actually use to suction the throat and nose of babies born postpartum that require that. You have a cervical seal. You can insufflate with 60 to 120 milliliters of sterile fluid. One of the common questions is, how do you know how much? For our utilization, we use 60 often when somebody has had a C-section and hasn't been completely dilated to 10 centimeters. That seal seems more than appropriate. And then for those who have an immediate postpartum hemorrhage after delivery of vaginal method, then sometimes we use closer to that 100, 120, just to give a little bit of a larger seal to kind of help create that vacuum. Once the low wall suction tubing is attached and turned on, you'll start to see the blood in that tube. And once you see the blood in that transparent tubing, you know that you've created that vacuum seal and it's working. So at points like that, you don't need to add or additional sterile fluid or anything to that expandable cervical seal. For the treatment time, the recommendation is at least 1 hour of active treatment time. And that is something in our standard operating procedure at the hospital now. We aim for that 1 hour time because that's significantly shorter than a lot of other indwelling devices. And then after the hour time is up, we shut off the and disconnect the vacuum and deflate that expandable cervical seal and really just wait for around 30 minutes just to make sure that there's no additional bleeding. And if there is additional bleeding, given that the device is still in place, you're able to just re-inflate that cervical seal and then reattach your vacuum and continue with the management of the system in uterus. So another poll is, which of the following are contraindications to the Jada system use? And untreated uterine rupture, unresolved uterine inversion, current cervical cancer, or current purulent infection from the cervix, or all of the above. And it appears that overwhelmingly 82% got it correct with indeed all of the above. So it's been used on multiple occasions after a treated uterine rupture. So after the hysterotomy has been repaired and there's still uterine atony. We personally have used it after we have inverted the uterus back to its anatomical position in the situations of uterine inversion where atony pursued after correction of the uterine position. Current cervical cancer is a contraindication. However, abnormal pap smears are not. And then when we talk about current purulent infection, those are more of the active ones that are ongoing that actually have the discharge rather than somebody who has a presumed intraamniotic infection, formerly known as chorioamnitis. So which of the following are not contraindications to the Jada system use? We have prolonged rupture of membranes, known uterine fibroids, scheduled non-labor cesarean delivery, or twin gestation, or none of the above. So once again, 74% of you did answer correctly that indeed none of the above. So none of the listed. Prolonged rupture of membranes is not a contraindication. Known uterine fibroids is not, as long as there is not somebody that prohibits you being able to place the device inside that uterine cavity. Scheduled non-labor cesarean section, also not a contraindication. It is recommended that the cervix be around 3 centimeters dilated or so in order to place the device. But that is something to always assess at the time of the bleeding. Even if it's a non-labor cervix, often they are dilated enough in order to place that intrauterine loop. Twin gestation, not a contraindication, or higher order multiples. And we all know that they are a significant risk factor for abnormal postpartum bleeding or postpartum hemorrhage. So according to the manufacturer insert, these really are the listed contraindications. So an ongoing intrauterine pregnancy. So for example, like an interval twin delayed, which I have yet to see a successful one of those. Untreated uterine rupture, unresolved uterine inversion, current cervical cancer, a known uterine anomaly that would not allow you to be able to place that kind of this actual loop inside the uterus, and then the infection, and then less than 3 centimeters dilated. So given that this is a new and novel device, there is limited literature on it, but we will review the Pearl study design, and this is the one that was published in our Green Journal in 2020. This here was kind of the first use of this in a multi-center study. This was a prospective single-arm, multi-center treatment study, so it was not, unfortunately, the randomized control trial, but this study was based more with the primary outcomes of evaluating the safety and the effectiveness of the Jada system in treating postpartum hemorrhage and abnormal postpartum uterine bleeding. It was conducted at 12 sites across the United States and enrolled 107 subjects. The primary effectiveness endpoint was control of that postpartum bleeding, and that was defined as not using any additional non-surgical second line or surgical interventions to control the bleeding after placement of the Jada system. And then the primary safety endpoint was examining the severity and seriousness of a long list of potential adverse events that could be related to the Jada system. So unfortunately, we don't always know exactly who is going to have a postpartum hemorrhage or abnormal postpartum bleeding, and we are unable to consent individuals in time of distress. So it required a large screening number of patients, where there was almost 16,500 individuals that were screened. We ended up consenting about 7,500 individuals. And out of that, 107 were enrolled who met inclusion criteria. One individual did not get the device placed or the vacuum wasn't connected. So our primary intent to treat analysis included 106 individuals. The key inclusion criteria for this study was at-knee related. So we ruled out other causes of abnormal uterine bleeding or postpartum hemorrhage that occurred within 24 hours after delivery, and the bleeding that was not controlled by uterine massage and by the use of uterotonics, which included at least Pitocin, but could also have included Methergin or Hemabate or Misoprostol. At the time that the study was planned and initiated, the definition of postpartum hemorrhage for vaginal delivery was still at 500. So the estimated blood loss was between 500 to 1,500 milliliters for vaginal delivery and 1,000 to 1,500 milliliters after cesarean delivery. For the purpose of the trial, there were key inclusion criteria, which included abnormal placenta, so concern for retained placenta like a focal accreta and was unable to easily remove the placenta. That the bleeding was determined by the investigator to require more aggressive treatment, so not able to work on more conservative management. If the individual had a diagnosis of a coagulopathy, and for the purpose of the study, they decided on the uterine size should be at least 34 weeks gestation. When we look at some of the key demographics within our patient population, race and ethnicity is kind of displayed there. And then there's also a table of the different patient characteristics where the average age was almost 30. The average BMI, which is not surprising for a lot of the trials that are conducted at these clinical sites, was about 35. Vaginal or the delivery type, there was predominantly more vaginal deliveries at 85% compared to C-sections of 15%. One of the reasons for this is a lot of the participating clinical sites were also participating in the randomized prophylactic TXA versus placebo for all C-section studies, and we weren't allowed to co-enroll. So it really did not allow us to consent a lot of the C-sections. The individuals did have some risk factors that were known for potential bleed or postpartum hemorrhage after delivery, such as a history of a prior postpartum hemorrhage in prior deliveries. Baseline anemia was in about 36%, hypertensive disorders of pregnancy in about a quarter of them. A significant amount were induced or augmented at 67%. The mean gestational age was about 38 weeks, and also 10% of twins and 14% was suspected macrosomia of over 4 kilograms. Also within this cohort, about 76% had an epidural placed during this, and then up to 10% obviously had like a spinal anesthesia or neuraxial anesthesia for their C-section as well. And what the study did find that there was indeed, in fact, effective control of the bleeding. So treatment without postpartum hemorrhage recurrence occurred in 94% of the individuals that did not require any additional treatment. And after the Jada system was placed, the median QBL, as we were able to measure that in the graduated canister, was 110 milliliters. Oh, I think one thing that was interesting about the study, but also something that's very applicable to real world, is when this bleeding occurs, interventions need to be timely. So one of the things that was looked at is how quick did this device work? When we use median minutes of time from initiation of the vacuum therapy, so that's when that's attached to the low wall suction as minute 0, within 1 minute, you were able to actually palpate the uterus and kind of feel it collapse. It was not required to use an ultrasound to see this or for placement. And none of the individuals within the study had that used. And then at 3 minutes was kind of the median time where there was observed control of the bleeding. And that really was kind of perceived when there was no longer blood accumulating in that tubing, it's really significantly slowed down, or that blood wasn't kind of increasing in that graduated canister. The median indwelling time for the device and for the device removal was 3.2 hours. Overall length of stay for the individuals within that Pearl study did not vary, with vaginal delivery around 2 and C-section around 3 days. I think one of the things that we were examining and kind of on a more granular level now is how long did the individual stay on the labor floor or higher acute floors? And did they go to postpartum with the Jada system in? At our institution and many other institutions, they do, as long as they are clinically stable, are transferred off of the floor, of the labor floor or the recovery bay with the device in place, and is able to continue maintaining its use on the postpartum floor. Or when we leave from the OR to the recovery bay or back to a labor room, we just unhook the suction and then replug it in when we get to our destination. Another area here to kind of draw your attention to is that bar graph on the right side, which is time to postpartum hemorrhage control or abnormal bleeding control. And overwhelmingly 65% of the participants had control of the bleeding within 0 to 3 minutes. And only 6% did it require more than or equal to 10 minutes. So one of the other things that we mentioned is we did look at the safety profile for this device. There was a very low rate of device or procedure-related adverse events. None of them were definitively related to the placement of the Jada device. There were some possibly related adverse events, and there was about 8, which majority of them were related to endometritis or presumed endometritis. There was 1 disruption of a vaginal laceration repair, and I was actually involved in that case. And it was an individual that pushed for a long time, had a 3rd-degree laceration that we repaired. After the repair is when the uterine atony and the subsequent bleeding occurred. And the repair itself, the tissue was very edematous, and anytime we touched it kind of bled more. So with placement, it did cause a little bit of a disruption, and we did require to put a single figure of 8 suture along it to achieve adequate hemostasis. And then as well as 1 case of bacterial vaginosis and 1 case of vaginal candidiasis. And all of these events resolved without treatment and without any serious adverse sequelae. Part of introducing a new device was to get feedback from the individuals who placed it. While we were at 12 sites, there was actually 99 individual investigators that placed the Jada device out of the 107 individuals that received it. 97% of the users said that they would recommend the Jada system, and 98% said overall it was very easy to use, with similar high percentages for that it did not affect the normal care, that it was easy to insert and properly position, also easy to remove, and that the instructions were clearly explained on how to use the device in 100% of the participants that filled the survey out. So in conclusion from the Pearl study, what we found that this was indeed definitive, and it did definitively control and mimic that physiological contraction to help control the bleeding, and that it was effective in 94%. You could visibly and observe the control of the abnormal bleeding through that clear tubing, as well as that graduated cylinder that allowed us to quantify the amount of blood that was lost. The vacuum does induce a physiologic contraction to kind of help that uterus to control the bleeding. There was a small amount of possible device-related adverse events that were rated as mild, and 3 were moderate. And that really in 3 minutes was the median time to control the bleeding, and that the indwelling time was only 3.2 hours, which is significantly less than a lot of the median times for other indwelling devices. So we're going to move on to another poll here. So I wanted you to estimate the percentage of your pregnant population that has at least 1 contraindication to the traditional uterotonics, such as hypertension or asthma. And they're kind of just categorized in percentages. Okay, so it's a very interesting breakdown with about a quarter of 0 to 5, 33% with 5 to 10, and then 10 to 25, about 25%. And as we increase in numbers, between 20 to 50% was about 13%, and then over 50% at 6%. And one of the reasons we asked this question here is really to kind of get us to think about different patients that we would really place it in, and how some of our classic uterotonic drugs can't be used in all the individuals. So another poll is, which patient would be a candidate for the placement of Jada? So A is 32 weeks status post-vaginal delivery of twins with abnormal uterine bleeding secondary to uterine atony. Another one is a repeat C-section at 39 weeks with a history of abnormal pap and a LEAP procedure and had bleeding due to atony. And then 37 weeks, kind of a delayed abnormal bleeding secondary to atony, as well as D, which is also one that had a uterine inversion, was corrected, and now with abnormal uterine bleeding secondary to uterine atony. And then the other, all of the above. So the correct answer there is indeed 45% of you got it. It's all of the above. I know that was a lot of words to read there in the time frame, but essentially all of these cases would be candidates for placement of the Jada system.